name is Cliff Robinson. I'm a radiation oncologist at Washington University in St. Louis, where I'm a professor of radiation oncology, director of clinical trials, and chief of the cardiothoracic and stereotactic radiation services. So the question is, in the setting of a resected small cell lung cancer, which is a relatively uncommon situation, what then would be indications for further adjuvant radiation? This is almost always going to occur in a specific scenario. CT shows a single pulmonary nodule. The PET-CT shows no regional or distant disease, and then the decision is made to either proceed with an empiric surgical resection for presumed early stage lung cancer, and then the final path reveals small cell, or biopsy the primary reveals small cell, and the decision is made to proceed with primary surgical resection at the outset. I think it's important before addressing the role of adjuvant radiotherapy, though, that we address the role of chemo. As we know, small cell, even in its earliest stages, is an aggressive, rapidly proliferating tumor with high rates of distant spread. As such, regardless of the local control modality used, whether it be surgery or radiotherapy, chemotherapy is the standard of care and critical. In the absence of chemotherapy, early studies using local therapy alone performed several decades ago now consistently demonstrated very low rates of cure. With the addition of platinum-based chemo, cure rates improved significantly, albeit still lower than we'd like, around 50% for even early stage small cell. Now, likewise, the reverse is true. With chemotherapy alone, rates of local regional failure are high, suggesting a role for local therapy, and therefore it's complementary. So I think in the setting of surgery and chemotherapy, the question then becomes, again, what is the role of adjuvant radiotherapy? Now, there's no large controlled trials in this setting, so we're left with first principles and retrospective series. And in general, I can think of a couple key scenarios. The first scenario would be after surgery, positive margins being present. The second is with regard to the lymphadenectomy. If there's a limited or no lymph node dissection, that's one scenario. If there's a lymph node dissection revealing frank positive pathologic N1 or N2 disease, that's another scenario. And lastly, if you have a good high quality lymph node dissection and it reveals no evidence of pathologic nodal disease, that's yet another scenario. So first, in the setting of a positive margin, it's generally accepted that adjuvant radiotherapy should be employed. Now, in this case, it's reasonable to consider a course of limited radiotherapy to the region of the positive margin, including generally the adjacent hilar and mediastinal nodal stations based on findings from the lymphadenectomy. Doses around 50 gray at 2 gray per fraction for microscopically positive margins and something closer to definitive doses of around 60 to 63 gray would be appropriate for macroscopically positive margins. Alternatively, if you're using a BID approach, 45 gray, 1.5 gray BID is also reasonable. Now, in the case of a limited or no lymph node dissection, treating the adjacent draining lymph nodes is reasonable to consider given the high likelihood of regional nodal disease for small cell overall. And you don't know if you haven't properly sampled the nodes. These should include, I think, at a minimum, the adjacent hilum, the subcarinal region, although it is also reasonable to consider treating additional nodes such as level 2 and 4, particularly if the pre-treatment PET-CT was suggestive of some indeterminate nodes in that region. Now, in the setting of a high-quality node dissection revealing node-positive disease, it's not felt that the lymphadenectomy is therapeutic into itself in that regard, and therefore it would be appropriate to treat the involved nodal regions as one would basically for definitive therapy. I guess stated otherwise, in this case, I would consider the surgery to have identified PET-CT negative nodal stations acting as a biopsy, demonstrating those nodes requiring therapeutic management with radiation. Treatment of the primary, again, would then be determined by whether the margins are positive or negative. Now, in the setting of a high-quality node dissection revealing node-negative disease, it's reasonable to consider omission of adjuvant RT. The primary benefit of mediastinal radiation is going to be in sterilization of the involved nodes, and if these have already been determined to be negative with surgery, the relative value of radiation therefore becomes questionable. So data for this is really limited. As far as I can tell, there's really only one recent paper that attempts to address this in any comprehensive way. Wakiam et al. At the University of Toronto, published in the Annals of Thoracic Surgery in 2017, did a national cancer database analysis. And while we always have to take those types of analyses with a grain of salt, they did do a nice job of trying to pare down into these specific questions. They overall found about 3,000 patients, and they found, perhaps not surprisingly, that patients who received adjuvant radiation after resection of small cell tended to be younger and were more likely to have higher pathologic T and N stage. They also found that patients who underwent sublobar resection, and then of course patients who had a positive margin, were also more likely to get adjuvant radiation. After trying to adjust for all those covariates, the overall multimodality After adjusting for those covariates, adjuvant radiotherapy was then found to be associated with a lower risk of death for patients with pathologic N1 and pathologic N2, but not N0. It was also not associated with better survival in these node-negative patients overall. However, it was associated with improved survival in patients receiving sublobar resection, which speaks to the nature of the extent of surgery as well. So again, while these are retrospective data, they seem to fall in line nicely with the overview that I just gave, suggesting that in patients who have had a high quality surgery, lobectomy with negative margins and node negative disease after a extensive lymphadenectomy, adjuvant radiation probably has limited value so long as the patient undergoes chemotherapy. However, with patients who have pathologic node positive disease or positive margins, there may be a role for adjuvant radiation.